Since the lights came on and now we can't see anything, I guess it's our signal that we should start. So thank you so much, everybody, for staying for the noon session on the last day of the meeting. We are very, very excited to present a bunch of really exciting things that are happening with the guidelines. So Melissa Boltz has been head of the guidelines subcommittee, and she has really been working very hard with her subcommittee group, including Edwina Moore here, to put together a process and an outline of how guidelines will go forward for our organization. And we're still working out some of the kinks with how to update guidelines, but she'll give you a little bit of an update, a little bit of a preview of that as well. In addition, as everybody knows, we have two wonderful guidelines that many of you have been involved with and have been working hard to put together, and they've both been accepted within the last month. And so we're going to give you a preview of the guidelines for renal hyperparathyroidism and also a preview of the adrenalectomy guidelines. But once they come out and are ready to be circulated, we'll definitely send out a mass email so that you guys can review them too. But really excited about today. So the first person up is Melissa Boltz, who will talk about guidelines.
All right, good afternoon. Thank you, Lynn, and thanks for allowing me to present today our committee's work. And I just want to thank everyone on the committee because we've worked really hard over the past year to develop a process on creating new guidelines and what to do with our existing guidelines and how we're going to revise them moving forward. So our committee came into existence actually in 2020. We were a small group of 4. So we were the pioneers of the committee, and we had a large task in sort of, carving our way, and we really became established in 2021 with a much larger group of people. And so one of the goals, as we mentioned, was really to create these processes and put them in place and how we're going to move the guideline development going forward. So really the goals of our guidelines are to assist clinicians in the evaluation and management of endocrine disorders, and we really need to succinctly and accurately summarize those evidence-based best practices when making these recommendations for surgical care. And so the development really requires multiple factors: creation of well-constructed clinical questions, a thorough review of the literature, and then an accurate grading method for determining the quality of that literature, and then really multidisciplinary group to interpret and craft these recommendations. And so with that, we decided to put together a 14-page document on how to do this going forward. So we're just going to give the highlights. So initially, we're going to have a form for clinical practice guideline topic submission, and we will be taking submission requests over the next year and collating them before the spring meeting. And the proposal form will be available on the website and includes really just three segments: a statement of need that's short, less than 500 words, important aspects, maybe 3 to 5 bullet points of care that are related to the topic, and then other organizations or patient advocacy groups that you might find would be needed on the sort of the overall working group. Regarding the committee selection or the working or writing group selection, it really should be a task force of specialists with expertise in that particular area of the proposed guideline, based on their scientific contributions and perhaps even national or international reputation. The group size should be limited to about 12 to 15 participants to encourage diversity and efficiency. And then we recognize that content experts may need to be added as time goes on to fill those knowledge gaps where literature may not be sufficient. Regarding the chair of the working or writing group, they will ensure that the group adheres to the methodologic standards that I'll speak about in a minute, and then really take the lead on editing and be responsible for guiding the final draft. We do encourage partnering with other prominent organizations, as this has shown to provide well-rounded guidelines. We also recognize that there is the creation of these guidelines rely on really the individual integrity of those working group members and their ability to create recommendations free of conflict of interest. So we have crafted a form that will be available also on the website, a conflict of interest form, and we highly recommend that this be completed of all writing group members at the start or just prior to drafting the guidelines. With respect to methodology, we need to ensure that the methods are transparent and that follow established and validated standards to ensure their wide adoption and use of evidence-based clinical recommendations. We suggest developing clinically relevant questions in PICO format, and then do the systematic review of published literature, but also allow for landmark studies. With respect to the methodology, we do recommend following the grade system as endorsed by the American College of Physicians, and then obviously there's the drafting, reviewing, and editing, which is pretty standard. The review process it has three components. The first is an internal review where the draft manuscript will be sent to our committee, and then we will have at least 2 members, ideally 3, use an appraisal checklist called the AGREE checklist. This has been noted in the literature, and it reviews 6 domains of the manuscript with 23 key outcomes to ensure that the guidelines are of sound scope, quality, clarity, and applicability. And then it will undergo an external review. We will ask that the writing group committee identify 3 peer reviewers to review the manuscript to ensure that we represent the target audience well. Additionally, as in the past, we will ask for AAES membership approval. This will be a 2-week period of comment for everyone in the organization to comment on the guidelines, and this is, as in the past, distributed via email. We also recommend obtaining feedback from any collaborating organizations, and this can be based on review of their organizational policy. The dissemination of the guidelines is just as important as the content, and that's really going to be the focus of the upcoming year of our committee. It should obviously be published in a peer-reviewed journal with which the endorsing society is affiliated. In the case of multiple societies, we recommend choosing a journal that has the largest and broadest readership. Post on the AAES website, and then we are working on other mechanisms of active distribution like social media campaigns and electronic-based education material, videos, things like that, maybe even some clinical workshops, or partnering with the other sponsoring organizations to present at their annual meeting. So that's the creation of new guidelines, and then with respect to the update process, there will be 3 components. We need to identify the new evidence, assess the need to update, and then formulate a new or modify the recommendations. So, scouring the literature, we found that most guidelines are obsolete after publication, after they're published at about the 3-year mark. So every 3 to 5 years, our committee will review the guidelines and determine which sections of the guidelines will need to be updated. We can also poll the membership to get their suggestions as well. And then we will submit the proposed sections for update to the council, and then every consideration will be made to contacting the principal author of those guidelines to coordinate the next working or writing group. The process is exactly the same as the creation of the new guidelines to ensure that we have the same standards going forward. But there is one additional requirement. They must include a description of the rationale for the update and any previous changes in the scope or purpose when compared to the prior version. It should retain the same format and subsections of the original guidelines so that this would facilitate easier identification of the updated recommendations, and the methods that are used for the search and identifying new evidence will have to be described. Alternatively, depending on the length or what subsections are required to be updated, we may consider publishing a separate paper with the updates only. So moving forward, as I mentioned before, all of the information that was presented briefly today will be uploaded to the website so that you can read the full document. If you're considering new topics for submission, that form will be posted along with our contact information as well as the conflict of interest form and the agree checklist so that you know how the guidelines will be evaluated prior to creating them. So our next steps are updating the primary hyperpara guidelines and then really working on the dissemination strategies for the new guidelines that you're going to hear about in a few minutes. Thank you.
Thanks so much. We're going to have a time at the end for questions, so please hold on to those until after the last presentation.
So I'd now like to introduce Dr. Sophie Dream from the Medical College of Wisconsin and Dr. Herb Chen from the University of Alabama, who will present an update on the new guidelines for secondary and tertiary hyperparathyroidism.
Afternoon, everybody. So Sophie and I had the great honor of working with this group to formulate the guidelines for secondary and tertiary hyperparathyroidism in collaboration with the American Society of Nephrology. So how that collaboration came to be is we contacted their leadership and they were very interested in participating with us. And their leadership basically gave us 3 people from their organization to work with. And so, from our side, these are the endocrine surgeons who are on our committee. And I won't read the names, but you can see there. And as I mentioned, we worked with the American Society of Nephrology. And these were the 3 individuals that represented their organization. And I'll just take a little bit of time because you may not know them. Stuart Sprague, who's at North Shore University, is the chief of the Division of Nephrology there. Sharon Moe, who's at Indiana University, she's the Associate Dean for Clinical and Translational Research, also the Director of the Division of Nephrology. And then Miles Wolf, who is at Duke University, again, Chief of Nephrology. So these are pretty recognized experts in the area, and we were so glad to work with them. And in the end, what happened when we all came to consensus with this document is that you heard the process of the review on the AAES side. The manuscript also went to leadership of the ASN, who basically had some feedback that we incorporated. And so the document really represents a great collaboration between the organizations. And I just want to say, we had a lot of members of the group, but there's always one driving person, and that was Sophie. Sophie did the yeoman's work on this, and I would really want to recognize her because although all our names are on it, her name should be bolded because of the effort she put into it. So Sophie, thank you for doing all that. And also per the recommendation of the committee, you know, we really appreciate everyone's feedback, that we got a lot of feedback, and really it's impossible to incorporate everyone's feedback. And also to make sure that the document represents a consensus by the group who put it together. So a lot of those decisions were made by me, so if there are any problems anyone has with not seeing their comments in, please take them to me. I'm going to leave the rest for Sophie to present the guidelines.
I will say that I do feel like the most of the work was done by our membership because you guys have a lot of research for us to have reviewed, and I just had the privilege to be able to read and compile that. So it was more you than me. I just put it together. So I want to start with a couple definitions. The first thing in this document is the only place you're going to see the word renal is in the title. That was very intentional. And talking to the nephrologist, they are moving away from using the word renal and nephron and all of those things that patients don't understand. So everything is either kidney or kidney related, just to make it more friendly to that kind of lexicon. When we're talking about secondary hyperparathyroidism, sorry, I'm like really short. We talk about it as hyperparathyroidism resulting from underlying kidney pathology in this document. It's characterized by elevated serum calcium, elevated phosphate low activated vitamin D levels in the setting of elevated PTH. For this patient population, elevated PTH is a little bit different than primary hyperpara in that it's 2 to 9 times the upper limit of normal, depending on your assay. For most people, that lands somewhere between 3 to 900. For tertiary, we talked a lot about this definition. So it's the autonomous function of hyperplastic parathyroid gland nodules. We usually see it in patients on prolonged dialysis or post-kidney transplant. In the post-transplant setting, we really want to wait at least 6 months before we're saying, yes, this is definitely tertiary and they're not going to turn a corner. It can be characterized by elevated serum calcium in the setting of an elevated PTH, but you can also have normal calcemic hyperparathyroidism. And some of that still needs to be tested out because there's not very great literature on the normal calcemic patients. We did use the 2010 American College of Physician grading, so the recommendations are either strong if the risks and the burden is not outweighed by the benefit of following through with that recommendation. If that's a little bit harder of a balance, then the recommendation is weak, and then the evidence was graded as high, moderate, and low. For initial so I'm going to go through these sections and highlight the things that were, I think everybody kind of needs to know from here. There are 4 recommendations in this section. The first, we took this straight from the KDIGO guidelines. It is in quotes, and we felt like we didn't want to be replicating that document just because the nephrologists have spent such a long time in reviewing the medical literature, so that we felt like this, for our purposes, really summarized what we wanted you guys to know. So in patients with CKD5, these patients should be on something that's ideally helping them lower parathyroid hormone level, and that can be some myriad of calcimimetics, calcitriol, vitamin D analogs. This should really be as their initial management, and this should really be done in a collaborative approach. The KDIGO guidelines recommend PTH should be somewhere between 2 to 9 times upper limit of normal. So for potential indications, we wrote this as potential indications because there, again, is not great data to say these are definitely the indications that we should be operating on these patients for, and it's very collaborative. So we're saying PTH exceeding 9 times the upper limit of normal in any of these indications. So uncontrolled hypercalcemia, hyperphosphatism, calciphylaxis or extraskeletal calcification, cortical bone fractures, proximal muscle weakness, bone and joint pain, uncontrolled pruritus, affecting quality of life, and then people who have high calcium and are waiting for a kidney, where that high calcium is going to compromise their kidney post-op. So parathyroidectomy has the potential to reduce cardiovascular all-cause mortality in patients with secondary hyperparathyroidism. So all those patients who fail medical therapy or have those complications that are listed in that table 3 or prefer surgery should be referred for parathyroidectomy. So knowing that there is a potential benefit for parathyroidectomy, especially in the tertiary patients, we recommended early referral for surgery. There's some data that says having parathyroidectomy within 278 days before or after kidney transplant helps with graft function. We're not recommending in this that patients definitely have their parathyroidectomy within that first 12 months. This recommendation is just to say these patients, if we're thinking that they're not going to resolve, should be seeing someone within that first year so that they're not getting a delay in treatment. So they should be coming in and talking to a surgeon and assessing whether or not they are a surgical candidate. So parathyroidectomy is treatment of choice for hypercalcemic tertiary hyperparathyroidism and should be considered on patients that are on long-term dialysis and post-transplant. There's really some pretty good evidence that says like cinacalcet can be safe to use in these patients, but to cure them, we really should be operating on them. So this imaging section has 2 recommendations in it that I'm going to go through. So we do recommend the workup and management of concomitant thyroid nodules in these patients if you are getting imaging based on the current AAES and ATA guidelines. Cervical ultrasound can be used to assess concomitant thyroid nodules and thyroid pathology. So we're saying, yes, if you are doing that, then you should continue to do that. It is worth noting that if in their workup you are finding a thyroid cancer, that in patients with solid organ transplant, we know that their overall prognosis is very similar to the general population. So if they do have a thyroid cancer, and we're saying their prognosis is 98% at 20 years, then they should not be getting precluded from getting a kidney transplant. So if you do routinely work this up, I think it's important to document that so that you're not then taking them off a transplant list in that process. The other thing, so we also know parathyroid imaging is a little bit less accurate in multi-gland disease, especially secondary tertiary hyperparathyroidism. And we are recommending that these patients are getting 4-gland explorations. So if you are going to get imaging, it's really to help find parathyroid glands in an ectopic location, not necessarily a eutopic location. And it can help with mediastinal ectopics. So if you're thinking about if you would consider doing a thymectomy in a patient and maybe don't want to do that, then a cystectomy maybe can help in that case. So this section has 21 recommendations, and I'm not going to go through all of them. I'm going to highlight them, but this is a very complicated patient population, and so we felt like this is actually a bulk of a lot of it. So vitamin D deficiency we know is very common in end-stage kidney disease and chronic kidney disease, mostly because there's an inability to produce activated vitamin D. So we do think that all the secondary patients should be getting some form of vitamin D repletion pre-parathyroidectomy. This one was a little bit controversial because we do know that it can be really hard to get people's vitamin D levels to normal. And we kind of went back and forth on how soft we should be about this, but I think the general idea is that they really should be on something, and there really should be an attempt to get them to some semblance of normal. That being said, they don't have to be normal before they go to the OR. So the next recommendation, so we know starting oral calcium and calcitriol in the preoperative setting can mitigate or prevent hungry bone syndrome. And there's some data that says within the first 2 days, or 2 days pre-op, that the rate of using IV calcium and length of stay can be reduced if you start calcitriol there. So we are recommending at least 2 days prior to parathyroidectomy that people are getting some calcitriol. Okay, so the use of calcimimetics. So we know people taking calcimimetics can have higher rates of gland weight resection, higher rate of bone turnover, and higher rates of hungry bone syndrome. We don't know if this is because of the disease that we're seeing is more severe or if it's because of the calcimimetics. The other thing we know is that it does not affect cure rates. So we know that calcimimetics can help lessen the negative effects of hyperparathyroidism and parathyroid hormone without affecting that cure rate. So it is okay to use it in the pre-transplant setting and in tertiary hyperparathyroidism patients. So we should be doing it. We didn't make a recommendation on when to stop it because there is nothing out there on when it should be stopped. I think there's a very, very old study that I couldn't even find there's like a lot of hearsay around it. I know some people stop at 2 weeks, some people stop at morning of. So whatever you're doing within your practice, I think is fair. I think this is a great place for someone to study if you guys need something to do. For antibiotic prophylaxis, so this follows the guidelines with anesthesia guidelines. Antibiotic prophylaxis, in most cases, with a transcervical approach, you don't need it. This patient population is a little bit different because they can have tunnel dialysis catheters beyond immunosuppression, have diabetes, and might make them higher risk for SSI. So we really want people to be taking a moment thinking about whether they need to be giving antibiotic prophylaxis, giving it at least for gram-positive in case we do need it, and then making sure we're adjusting for kidney function. I think that's really important. Okay, so surgical planning and parathyroidectomy. There are 16 recommendations here. Some of this is like very summative because it gets a little bit repetitive between secondary and tertiary, so I tried to group some of it. So this first recommendation, so the patient's dialysis status and their likelihood to get a kidney should be a big factor in what operation we're planning on doing. So whether or not they're getting subtotal, total with auto transplant, and total without auto transplant, you really need to know what their status of their kidney function and their dialysis is. So for parathyroidectomy for secondary tertiary, we are recommending that these patients should have a 4-gland exploration every time, and that kind of goes along with our imaging. You need to be looking at all of the glands. Based on what we're seeing in there, I'll talk again a little bit later about that. But we're saying try not to avoid the caps. Do not disrupt the capsule unless you're going to take it out, because it can devascularize it. And then when we're doing subtotal, we want to make sure there's a well-vascularized remnant of the most normal appearing gland. So subtotal parathyroidectomy is the preferred approach for secondary tertiary hyperparathyroidism. That's because when we're looking at all the data weighing the risk of persistent and recurrent hyperparathyroidism versus hypocalcemia, that really is, the data supports doing a subtotal. The choice of operation obviously should be left to the individual surgeon and the patient factors. We did want to give some leeway with that, so there's a recommendation that's saying that especially in tertiary, you can do limited resection if you go in there and see that there's only 1 or 2 large glands, because there is a subset of these patients that could have primary as well. So if you go in there and they're not all 4 are big, then 1 gland can be indicated. So total thyroidectomy without auto transplant should not be performed in people who have CKD that are going to get a kidney transplant, because the rate of permanent hypoparathyroidism is too high. And then in patients with tertiary hyperparathyroidism. And then cervical thymectomy. So this can be helpful in patients that have secondary hyperpara to reduce the likelihood of persistent recurrent disease, and should be considered in patients with tertiary. Right. So we felt that the use of intraoperative PTH for secondary tertiary was somewhat useful. The current literature, we can't really provide a definitive recommendation. So our recommendation is that you should be familiar with the data if you're going to be using it. And then we have this table that I'm not going to go through here, outlining all of the studies that are there. There's about 13 of them, and they all recommend something a little bit different. So it was pretty hard to say what the one right thing to do is. But yeah. So section 7 goes, I don't have any recommendations in this section, but it does review the multiple emerging technologies and the things that we can be using to treat these patients. So this is mostly here for reference if you are considering using any of these, or if you have questions about them. It's there. Outcomes. This section has 3 recommendations in it that I'm not going to go over. It actually very closely reflects some of the primary hyperparathyroid guidelines recommendations, and we reference those as we felt was appropriate. And then reoperation. So this is a little different in terms of recommending for whether, actually this recommendation is the same from this primary operation. So reoperation, again, we're saying medically refractory disease in patients that have persistent hyperparathyroidism or recurrent after having initial parathyroidectomy. For imaging, the preoperative localization, we're saying if you haven't gotten imaging and you're going back in a second time, it is important to localize in this setting, and to make sure that your imaging is really based on your local expertise. Again, we want you to be finding all the glands and either doing subtotal or total with auto transplant. And then consider if patients have a graft, then you have to consider where the recurrence is, and then if you need to do graftectomy, then that's what we should be doing. There's also a couple of clinical highlights in this document. This one I included because we have no commonly defined definition of cure, and I think that's why I include this one in here, because I think in terms of reoperation and saying, okay, you've been cured, we can't really say that, because these patients are on a journey of whether or not they have a kidney or they're on dialysis, and so every patient is going to land in a different spot. So we don't have just one, say, cure for saying, like, you have secondary and we've cured you. And that is it. Thanks, guys.
Great, wonderful, thank you. Next, we have Nancy Perrier and David Velasquez Fernandez representing the adrenalectomy guidelines.
Good afternoon. Thank you, Sophie, for that summary. Dressed in full regalia of reminding us of the adrenal gland and our zebra diseases. That's what the yellow color's about for all of you out there in the audience. We hope you take the spirit of our committee, because it's an honor for us to tell you about the progress and the process of what we have done over the last 2 years. We hope in the next few minutes we'll tell you a little bit about how the committee came to be and who is on the committee, the discussion and the charter statement that we made at the beginning of the process about what our intentions were, the outline of how we came to what questions we were going to answer, the timeline that we set and how we did that, so that, and we're doing this so that those of you in the audience coming behind us will learn this process and will be able to use this in future guidelines. And then the tools to really elaborate on the grade system and the tools and to show you how we actually used it in an expert panel setting. And then to explain to you the executive summary and the completed manuscript that will be in press at the end of this month in JAMA Surgery. This is a smattering of the members of the committee, and we took this picture yesterday right out here in the front lawn, and really the joy that we had working together since the August of 2020 was really the highlight of the entire, the highlight of our entire work program. I want to specifically draw attention to Kwan and Lynn, who were co-chairs, and their guidance and leading us through this, and then particularly to acknowledge the folks like Sylvia Asa, who was a world-class pathologist and worked with us. Vivian Strong was a loud, great voice from Memorial on the oncologic stands. Camilo Jimenez, who is the international expert on pheochromocytoma. Irina Barros, who is just such a bright light in the world of endocrine and all that was macronodular and cortical excess. We had representation from the NIH, from the radiology group. The head of the abdominal imaging section for the Academy of Abdominal Radiology was a member of our group. But it was a wealth of perspectives, and what I learned as a leader in doing that was the importance of bringing people together who didn't think we didn't think alike. They weren't friends that we brought together because we wanted it. We all came from a different perspective of diversity of experience, but we all had a lot of experience in adrenal. And then we sat and listened, and we did a lot of listening and a lot of talking. And we set our course for about 6 months before we even began. And this is what we talked about. We sat together on calls and talked about what is the purpose of what we're doing, and we set in place a charter statement so that at times when we found that we were not just going to do things on consensus, we were going to go back to the work that we had done up front about the purpose of why we were doing this. And our approach was we didn't need a set of guidelines that gave expert opinion of this and that. That is already available in the literature from the Endocrine Society, from AAES. We wanted to ask contemporary, current questions that face each one of us in our practices every day. When do I do a cortical-sparing adrenalectomy? When do I use a venous vein sampling? But those questions, and so that they would answer succinctly what we need in our practice. And then the scope of that, which you see here, was just so that it could be enriched for all of us taking care of surgical patients, whether we're mid-level providers, whether we are anesthesiologists, and that was our goal, and we did that, and this is the artwork of what we do and the brightness, and again, to really complement the wisdom and the grace of Quan Du and Lin Hua Yip, who really were just such amazing strongholds. And the picture in the middle is an artwork representing our fellows in the audience. And the adrenal gland is often, it looms large. It's sort of it's the gland for us that is all a little bit different because of its positioning, whether it's left, whether it's right, whether it's transabdominal, whether it's retroperitoneal. And so these guidelines are for y'all. And we hope you take the wisdom of them. And so we actually have you here as who we were writing to. Lauren Sanangelo did a great job with all things AAES on helping us do it. And it would be remiss to not really compliment the work of Yasmin Kawaja, who is our administrative assistant and the director of our section at Anderson, who was just a lifesaver coordinating all of our references and helping us with all of our meetings. And we had a protocol along the way when we met monthly that we gave out awards to each other for things that happened during the month, and we call it the Steroids Award. Phil Smith was an honorary recipient of that award many times, Aaron and all of their work, and again, but in this case, I think the whole committee would agree that Yasmin truly gets the Steroid Award in helping us get this to this manuscript with references, hundreds of them completed. So we looked at all the topics. This is what we clustered when we first met and started thinking about what we wanted to address. We ended up combining orphan diseases with the metastases and other things that were non-endocrine primary in the adrenal gland. You see this list here. We gave ourselves responsibilities as first author and senior author to really, we did our homework and we presented summaries of the literature to each other. We filled out forms, we executed, we quantified and qualified. We sent it to each other before we met on the calls, and then on the calls we discussed it, and then we wrote, again, evidence-based what we wrote, and then we would revisit it. And you'll see here, again, great work. You see the diversity of where everyone's from. We used the PICO format. We had the beauty of, on our committee, we included Gordon Guyad is the world's expert on writing grade. He wrote those original, how do you really write guidelines? And Gordon was a part of our initial planning. And we actually had one of his colleagues, Miha Han, on the committee with us. And she would constantly bring us back to center. No, you're not just going to write. It has to answer a question. We have to be able to suggest. We have to be able to recommend. We have certain words to use. But this is what PICO looks like, and this is what we frankly struggled with as surgeons. And I think Cord and Lynn will remember, and Tom, on some calls, we met for 2 hours, and we tried to never go over 2 hours, just saying, we don't know how to ask this. We don't know how to ask to tell patients, do you come off of cardiovascular medicines after we take out your Aldo or not? How do we put that into PICO format? And saying maybe PICO wasn't written for surgeons. It really wasn't written for internists. And so, but we kept on each other, and we used this. And PICO stands for the population. What is the intervention? What are you comparing it to? And what is that outcome? And so we asked these specific questions, and then we sought the literature to answer these questions. Can you make it an answerable question? Because if we couldn't, we didn't use it. Inclusion criteria, we searched for the studies, we extracted the data, put it in chart forms, we synthesized it, and then we presented the results to each other, and everyone read through the results. And so even though you saw those of us that had the specific homework of what we did, we all participated in all aspects of reviewing it. This is the timeline, again, of how long we took, which was about 6 months of just gathering our thoughts, deciding what questions were most relevant, and then in January of 21, we started our work. We met on Wednesdays, the third Wednesday of every month for 2 hours. We would communicate ahead of time, deliver the deliverable of all of the data context, what was written, we would read it, we would discuss it, and then we would re-prepare it. And it took us about 9 months. We then put the document together, which was where the work really came for all of the different components of all the references and the charts and the tables. And then we set it out for internal review, which we totally appreciated, and then for the membership review. And then we had the work of then beginning the submission process. So these are the two components to learn when you read these guidelines and others. The two components are, what's the quality, the certainty, and the confidence of the data that you're using? Is it very low? Is it very high? And to where on that spectrum does it fall? And the second part of that is, now that you have that data and you've synthesized it, how strong is that evidence? And it can only be strong or weak. So everyone is quality, and then the second one is the strength. And these were the facets that we used, that we kept coming back to. We made charts, and we list each article, and we quantify it this way. the quality, the limitations of the study, the confidence of where it came from, whether it was retrospective, whether it was a single group. And we graded every one of our pieces of information. And this is what the evidence summary tables look like. And this is what we gave each other. So for any of you in this audience, if you have any questions about the recommendations, you come back to us, and in that manuscript you will see, and we have the evidence data tables to show you how we got there. Because then this would begin our discussion. And we did a lot of listening to each other from our different views. And then this is just to remind you how we use the strength component, what was desirable. We use the desirable consequences. Are we talking about death? Are we talking about removal of being disease-free for adrenal cortical carcinoma? A lot of interesting things, and I was remiss to not mention Gary Hammer was another great, thoughtful, the president of the Endocrine Society at the time. He was a member of the committee, and he kept a straight and narrow. And this is how we got to the strengths of the recommendations. So you'll see, they weren't just us telling you, yeah, we're telling you should do this, and we really are telling you loudly. No, it's not in the tone of our voice, it's in the quality of that data and where it fit on that factor. And so you'll see listed with each one where it came from. So this was our final process, and you'll read every statement starts in the grade format of we either recommend it or we suggest it. And if it was strong data, we will give it, and it says to you, we recommend. And if it is weaker data, we tell you we suggest. This is not totally evidence-based. And this is just to show you of what happened when we came to the beginning of January and we had Tom on cue. We promised we were going to have this delivered and in the field goal for his meeting. And we thought it would be easy, and we ran into a few roadblocks, which you can see here just in we addressed every comment that y'all brought to us from the membership. We went back to the document. We then went to the NADF, who reviewed the document, and that's the patient organization of 6,000 members. We took to heart what they brought back to us. The AAES gave us the recommendation. The Endocrine Society, the Society of Abdominal Radiology had input. We put all of that into play, and then we submitted it. And then the JAMA Surgery had reviewers. And actually, amongst this audience, some of you may have been reviewers, but those were the biggest critics of the document on it needs to say this, and we had to come back and say, we know you think it needs to say this, but actually the data supports this. And finally, on May the 2nd, we all raised our hands and it was accepted. So we felt like our job was done. And again, we checked those boxes off one by one, and there they are. They're the 7 categories. And we are going to present to you, not all of them today. Wait, they will be coming out on JAMA and JAMA Surgery. There will be an executive summary which will be immediately available for all of you to download, which lists the 26 clinically relevant questions that we asked. And then following that will be a full manuscript that will come out, and it will be the 222-page document of all of the data, all of the references, all of the tables that support the executive summary. I know that confused a lot of us when we did parathyroid, because it came out as 2 documents which you recommend and recognize. So wait for those. The executive summary lists everything, the manuscript, everything in detail. And with that, I'm going to deliver to you. David and Lila were just champions on every call, and champions for Cushing's and for FIO, and David is going to introduce the guidelines to you. And it's all yours.
Thank you very much, Professor Perrier. As she has mentioned before, these guidelines, these suggestions and recommendations were based on not only medical evidence, but as well as methodological and statistical evidence. So it is a tremendous pleasure for me to read some of these suggestions or recommendations. So, for example, in recommendation 1.4, we do not recommend routine scheduled follow-up of a non-functional adrenal nodule lesser than 4 centimeters with benign imaging characteristics and non-contrast HU lesser than 10 units, because the risk of developing malignancy is very low. For example, about autonomous cortisol secretion, is the most common hormonal excess to develop during surveillance and thus may be reevaluated at 2 to 5 year interval. And this was a strong recommendation with low quality evidence. All these recommendations or suggestions are based, of course, in the best currently published literature available, and as well responding the PICO answers, the PICO questions. So for recommendation 2.2, we suggest that in patients with younger than 35 years of age, with cross-sectional imaging demonstrating a unilateral adenoma and a normal contralateral gland, AAES may be deferred because adrenalectomy directed by CT scan alone has a cure rate similar to adrenalectomy guided by AAES. So, however, AAES should still be considered for patients older than 35 years of age, and this is as well weaker recommendation with low quality of evidence. For 3.2, for example, in patients with bilateral macronodal hyperplasia, we do suggest consideration of unilateral laparoscopic adrenalectomy in patients with Cushing's syndrome as attempt to achieve biochemical remission of hypercortisolism without causing permanent adrenal insufficiency. This was also a weak recommendation with low quality. And for the recommendation 5.2, we do suggest that in setting of the radiographically indeterminate mass, image-guided biopsy will be rarely performed and reserved for patients in whom results will change the overall disease management and be performed only after confirming lack of hormonal excess. For recommendation 6.2, because of the decreased rate of estrogen dependence, we recommend consideration of cortical-sparing adrenalectomy in patients with bilateral pheochromocytomas if technically feasible. However, patient goals of care and higher risk of recurring pheochromocytoma should also be considered. And in summary, the 2022 guidelines that incorporate advances in technical skill or advances in our understanding of disease, and we are planning as well to translate these guidelines into Spanish, French, and Portuguese to begin our dissemination strategies throughout Latin America. And thank you for the A team for the hours of dedication, commitment, and discussions. It was a huge learning experience for all of us to be custodians of what we love. Thank you very much.
Before we get to questions, I just want to also acknowledge that Nancy was a fabulous leader for our adrenalectomy guidelines and really put a lot of work into them. And so I really appreciate her leadership and learned a lot from the process as well. So, all right, we have about 15 minutes for questions. If anybody has any questions about either the guidelines process or either of the two guidelines that we just talked about.
So we can start on the right.
Hi, Kwan Du from San Francisco. This is actually wonderful to hear how the guideline process, now there's a formal process and the two guidelines. I have one question regarding the renal hyperparathyroidism. I'm concerned a little bit about the confusion of terminology. In the surgical literature, usually tertiary is identified as post-transplant hyperparathyroidism. And I know that the original literature, tertiary, is reserved for people who become hypercalcemic while they have kidney failure. And my biggest concern is that the way the guideline is written, the nephrologist would understand what it means. But the rest of the people may be confused. And I don't have any suggestion about how to fix it. I'm just concerned about that. And another thing related to that is that it means that your recommendation for tertiary would include both people that are still on dialysis, that are hypercalcemic, and people that already have their transplant. And those are very different group of patients, as we all know. So anyway, that's just a comment and a question for you.
No, I think that we struggle with that, Kwan, about the definition because there was no consensus about the definition, and especially from our nephrology colleagues who strongly, I think as surgeons we tend to refer to tertiary as post-kidney, but they definitely do not. And so the compromise was to agree to terminology that included both, but be strong in the recommendations, or try to be more specific about the recommendations about when surgery, because they, surprisingly, they were in agreement with us about the strong role of surgery, well, almost everyone, but we could convince the last one. And I think, and actually, the recommendations, we pushed them for the recommendations for surgery for secondary, and we were able to get them to agree to the ones that we recommended there. But yeah, do you want to add, Sophie?
Yeah, so I think I personally learned a lot about the process of like the transition from secondary to tertiary and working with a nephrologist, and they wrote that whole first section on the pathophysiology, and I spent a lot of time trying to make it readable to me, and I am a outcomes researcher, and I'm a forest, not trees person. So I think if we spend the time to read that, it makes sense to include both of those as the definition. So I do agree with the way it's written now. I don't know that, I was pretty confused before I did that, so I think reading that helps. The other thing is, when you look at the perioperative, the parathyroidectomy, that section 6, the first recommendation is to consider the patient's kidney status, and I think that that was really where we wanted that there, because the rest of it kind of lumps it into secondary, tertiary, but we wanted that to overarchingly kind of be what you're thinking about in the background.
Thank you. On the left.
Yes, Sarah Altman from Dallas, Texas. Following up on another question on the secondary and tertiary, two questions. First, a lot of our patients will have calcitriol bundled into the dialysis center payments, and so my partners and I will sometimes struggle with being able to get patients calcitriol and at the doses that we're anticipating for the needs post-op. So that's one. Two is, what about patient medical compliance and being able to decide when that compliance is at a point where proceeding with surgery is going to be safe? Thank you.
I don't know if I can answer that.
So just to ask specific, Sarah, when you mean the compliance with their medications before surgery, after surgery? What do you mean exactly?
So like my typical secondary patient doesn't want to take Sensipar, doesn't want to take Foslo, they don't want to comply with the low phosphate diet, and they're under the impression that by me doing the surgery, it fixes all of it, and they won't have to be on any medicine afterwards. And oh, by the way, they don't take their HIV meds, and they don't take their diabetes meds. So for some of those more challenging social patients, other than education, is there a certain timeline as far as partnering with them and the nephrologist to help improve medical compliance, and then having a certain threshold of, understandably, the side effects of the calcimimetics are not desirable, and they're wanting, but they commit to compliance afterwards?
I think that's a really tough situation, because I mean, if they're not going to be compliant in the pre-op setting, they're not going to be compliant in the post-op setting.
Yes.
I think you need to move. I'm just kidding.
Thanks, Dr. Babanga.
Hello, thank you so much. Juliana Bobenga from Cleveland. I have a question about the secondary and tertiary hyperparathyroidism guidelines. I saw that you were recommending subtotal parathyroidectomy, and I'm wondering if you're making any recommendation regarding cervical thymectomy.
Yeah. So it is helpful in patients with secondary and should be considered especially, sorry. Okay. So yeah, it's a secondary, and then in some patients with tertiary. I think if you're weighing that risk of like recurrence, especially if you're doing a total, you should be doing cervical thymectomy. So if it's part of your practice and you're not getting imaging, I think it definitely is helpful to do that.
But the guidelines say definitely for secondary, and
Right.
then should be considered in tertiary depending upon what your operating plan is.
Can I make a piggyback to your question? Because I find that also confusing for two reasons. One is, in our practice, when we do subtotals for secondary, the patients have tremendous collateral blood flow from prior vas cath catheters, perm caths, and as Libby alluded to yesterday here, we often even get ultrasounds to understand the anatomy of what's, often they have a clot in the IJ, And so the collateral blood flow, and our job on that table at our institution is on and off as fast as we can. We open, and they often have platelet dysfunction, and they ooze. So they're oozers. So we don't do a cervical thymectomy because that's added operation around big veins, and there's more chance of bleeding, and we don't want them to ooze because we don't want a hematoma to compress the remnant.
Yeah, and I think that in those cases, if you're not going to be routinely doing that assessed maybe to make sure you're not missing an ectopic is helpful. And that, I think Dr. Niger's paper shows that, and that was kind of where that came from. But I think in those cases where if you don't feel comfortable doing it every time, they probably should be doing some sort of imaging to make sure.
But just knowing that the AAES names are on the guidelines, and someone's going to pull that and say, the AAES says, because like we don't get cestomemes on secondaries, because it's multi-gland disease, and so we just want to make sure you're telling us, and we know, so we can know how to massage it with direction.
Yeah, I think the challenge is, of course, as we've learned from this meeting, we all do it so many different ways, and whatever guidelines we put out are just guidelines, right? They're not telling you this is what you absolutely have to do. You have to use your judgment for every patient you operate on. I mean, all of us probably don't adhere to every single guidelines in the already published, primary hyperparathyroid and thyroid guidelines, at least.
So maybe it can say you may perform a thymectomy if you like.
Thank you. Next question.
Hi, Peter Angelos from University of Chicago. So thank you all for all your efforts, and I applaud you and the entire writing groups. I mean, these are really valuable things for us all. Yesterday at the Ethics Committee meeting, we had a long discussion about what constitutes conflict of interest and how much conflict of interest is acceptable. And so I'm just curious whether we have an association standard for the number or the percentage of authors on each guideline that has a conflict, because I think that also has an impact on how widely respected our guidelines are.
I can answer for the adrenal component. And that's such a great point, Peter, and we addressed that early on, straight on. Of the experts, everyone had to turn in their conflict of interest sheets that were kept available on file for everyone to see and to know, and those were updated at 6-month intervals. So and at the beginning of each call, we knew who had a conflict, we all knew, and who shouldn't be on that call. So we addressed it. The number of authors, and I know that I totally respect the committee on how many is enough, 12 or 15. We ended up with 21 authors because of the expertise and seeking it. And so obviously there were folks that had income coming in elsewhere at time periods, but they weren't a part of the discussion or the comments for anything that pertained to that. And we used that documentation to totally have it available for further reference, and at the beginning of the calls to mention that.
Yeah, I think it's a great point, Peter. We obviously ours also have a full list of any potential disclosures, and our nephrology colleagues did have a lot of disclosures, but in particular, we were very sensitive looked is at in the sections they particularly contributed content and comment on, did they have a conflict of interest with that particular topic? And we felt that they did not, and so I think, yeah, we very much were sensitive to that.
And you, I'm sorry, Lynn, go ahead.
That's okay. I think you bring up a very crucial point, and in that document that we put together, we did specifically say that there has to be a plan and a method of managing conflict, and it has to be clearly disclosed in the method section or in the early part of the guidelines to make sure that it's appropriately managed.
And my question is in no way to impugn anyone's integrity, but I do think that if you have a guideline that has 75% of the authors with a conflict listed, that creates an appearance of a conflict for the entire guideline. And so that may be something for the Guidelines on Guidelines committee to think about an overall standard.
Thank you. Excellent point.
Well, I have no questions, of only comments. So, Actually, I wanted to dovetail off of Dr. Angelos just for a second. I have quite a lot of experience with mitigation of conflict of interest based on what I do for another organization. And the best time to identify and mitigate conflict of interest is at the time that you select authors. Before you begin the process, you identify everybody's conflict of interest, you get them to sign off on it, and then the co-chairs need to then determine if the conflicts can be mitigated or not, and then how they will do that, and then it all has to be extremely transparent. And I applaud you guys for doing that stuff. My second comment is I was on the adrenalectomy guidelines. That's my declaration, I guess my conflict. But I do want to echo what Lynn said. Tremendous leadership from Nancy Perrier on this, and it was really a fantastic process to be a part of and to witness. And I feel like I didn't do much work at all, but it was great. All right, and then finally, I wanted to say this. I think guidelines always, you read them and you say, I disagree with that, or that's not the way I do that, or I think that this is not right. And guidelines are very fruitful for the next generation of research papers. So everyone in this room ought to be thinking about, I got to get my hands on these guidelines so I can think about the abstract that I'm going to send to Birmingham, because this is exactly the way it works. Guidelines create controversy sometimes. We disagree, we think about it, we say, let's prove what we've always known, or something like that, and it turns into great research. So everybody keep that in mind. Thanks.
Excellent comment. Are there any other questions? So we will draw this session to a close. Thank you to all of our speakers for their time and excellent answers. The next session is at 1:30 for the final scientific session, but until then you can have a coffee. Thank you very much.